that could be easier to understand, and hopefully this talk will motivate you to understand better this condition, and also to encourage your clinicians to maybe at least to raise the awareness for the genetic predisposition. So I am Pilar Rivera Ortega. I am one of the consultants of ILD, of the ILD service at the Southwest. It's a year since I started working here in Exeter, after being working for 7 years in Manchester as the clinical and research lead of the ILD unit there. I was working very closely with Dr. Nasia Chowdhury, that I'm pretty sure that most of you are familiarized with. She is fantastic. She's an expert in ILD, and I was very lucky to work with her for many years in Manchester. And then she went to Northern Ireland, and I think came here to the Southwest. The next slide is a bit, you will see this figure, it is about the classification of the ILD. Although we have a new classification of all the interstitial lung diseases, that you know that is a big group of almost 200 diseases. So when we talk about interstitial lung disease, it's not one disease, it's a big umbrella of 200 diseases. And within this group, if we want to split between predominantly inflammatory interstitial lung diseases or predominantly fibrotic interstitial lung diseases, what we call fibrotic interstitial lung diseases is sometimes we abbreviate as pulmonary fibrosis. But when we say pulmonary fibrosis, one more time, it's not one disease. We have around 100 different types of pulmonary fibrosis. And how we differentiate between them is if we are able or not to identify the cause of the disease. And this figure tried to explain what was the previous two classifications for interstitial lung disease. One was I think it's a while ago, from 2002, and the second one was from 2013. And for teaching purposes, I put this, I think it's red line here to explain what is on the left side. That is what we call idiopathic interstitial pneumonia. And what is on the right side, all the ones that somehow we know what is the cause of the interstitial lung disease. And just a thing is, of course, many of you already are aware of, but idiopathic is a medical term that we use to describe when we don't know the cause of the disease. So it's a fancy term that physicians and clinicians we use to describe that we don't know the cause. We call idiopathic. Sometimes we use as well the name cryptogenic. So cryptogenic, although it's not exactly the same of idiopathic, but for teaching purposes today we will consider the same. Sometimes when you will, I think it's read any report that said cryptogenic or said idiopathic, that is a medical term. They are medical terms that means whatever you are having, we are not able to identify the cause at the moment. Okay? And we have several types of idiopathic interstitial pneumonia that, although the name is pneumonia at the end, that doesn't mean that it's associated with infection. It's a different type of inflammation, and sometimes there is no inflammation directly is scarring there, and also volume loss in our lung. Well, I am spending quite a lot of time on this. I'm sorry if many of you already are familiarized with this that I am explaining. It's because in this graph that we don't have the 200 diseases that I mentioned. There are only a few of them. But if I will ask you where exactly, or where is in this classification, where will be the location of familial pulmonary fibrosis or familial interstitial lung disease, the answer is there is no one location, because actually any of the 200 type of interstitial lung disease possibly can have genetic predisposition. And if they have family history of interstitial lung disease, we will call them familial interstitial lung disease. Therefore, the first take-home message for this slide means familial interstitial lung disease or familial pulmonary fibrosis is not one disease. Therefore, you will not be able to identify this disease in the algorithm or flow chart of the classification, because any of the 200 ILD conditions may have genetic predisposition, and if we have that alongside family history, we will call familial interstitial lung disease. So that is the first take-home message. The second take-home message, and let's start here about these two figures. Let's introduce the concept about the telomere, and I will use an analogy. So many of you now, if you will look at your shoes, you will see some of your shoes maybe will have the shoe lashes, okay? And if you see at the end of your shoes lashes, there is this area, plastic area, at the end of your shoe lashes that is really important to keep your shoe lashes well preserved. Otherwise, if the little plastic area is lost, the shoe lashes are not the same, and maybe we need to change them. So imagine now that the shoe lashes are not anymore done, that they are our chromosomes, that they are, and all of us, we have our chromosomes, that they were our genes, and all the genetic information is everything that we inherited from our parents and grandparents and so on, all the information that we inherited when we were born, all of this information is in our chromosomes. So now imagine that the analogy is between our chromosomes and the shoe lashes. And the caps of the chromosomes, these areas are the areas that we call telomere. And these areas are really important because they will keep all the information that is inside our chromosomes very stable. And what happened when we were born, of course, as babies, we have length, at the length of the telomere is quite well preserved, and that is the reason if as babies or during our childhood, for sure many of us, we fall, we have injuries, and when we are, I think it's as a child, I think we have an injury, and very quickly we have a very good healing. Why? Because that's the same that is happening on the skin can happen in any other organs, because that is part as well of the work and the very good role of our telomere. We have a very good length of the telomere, and everything that is at the cap of our chromosomes, they are healthy and they are working at the maximum power. But as soon as, and all of us were getting older, the length of the chromosome is getting shorter and shorter. That means the length of the telomere is reducing. And that is part of the natural aging. But if we inherited already a short telomere, that means we already inherited a reduced length of this cap of the chromosomes, and that will be the figure that you can see here at the bottom right. If we inherited short telomere when we were born, across to our life, we can have some environmental factors, maybe exposed to tobacco consumption, exposed to some fumes, to some chemicals, air pollution, so on. And then we will achieve some threshold that will be the trigger to be able to develop a disease. And that, of course, this threshold will be achieved sooner compared to another patient that maybe they were born with a normal length of their telomere. And that is how I think we can use the information of the genetics to understand better your condition. And therefore we can customize the management plan for you, and hopefully we can establish a management plan to prevent these conditions for your children or other first degree relatives. So that is why we as ILD community, we are very interested about the telomere. Remember, because during this talk I will mention several times this word. Remember one more time, telomere are the caps of the chromosomes, very important part to keep stable all the information in our genes, that they are the basic unit in our chromosomes. And now, talking about the genes. All the genes, by the way, they are like abbreviations. They usually are a combination of letters that could be consonants, I think it's, and also sometimes numbers. You can see here all of them in purple color. A few of them that could be the TERT, for example, here. Other here, I think the ARTEL1. What are they? They are genes. If we have some variants, that means these genes that all of us, we have them. But if these genes have some changes compared to the usual one that should be, if we change the normal gene, that means that the protein that they need to produce will be different. And if the protein will be different, if this protein is the main source of a particular organ, and this organ could be the lung, that means maybe the lung function could be different, or we can have an organ failure. For example, if we're talking about the bone marrow. That is why it's really important to understand how our genes are working. If we inherited a different or a variant in our genes that in the past we used to call mutation, but we don't call anymore mutation because it sounds a bit bad, isn't it? So we call now variant, and sometimes we call pathogenic variant, because pathogenic is a medical term to describe a variant that is causing a disease. In that case we say pathogenic variant, but just for you to remember, that is what in the past we used to call mutation. So if we have a pathogenic variant in those genes, particularly this the TERT or the ARTEL1, the PAM, all of these genes are the genes related to the telomere. So, and we can see that these genes can be, sometimes we can have variants related to diseases like idiopathic pulmonary fibrosis, but the same ones we can have variants, and they are associated with connective tissue diseases, associated to pulmonary fibrosis or other type of conditions. And then many of you maybe are aware that in September this year, so just a couple of months ago, we have a new classification of interstitial lung diseases, particularly interstitial pneumonias, that is in use global-wise. So if suddenly you see new terminology about how we describe your CT scans, or how we describe your lung biopsies, or how we document them, the way how we describe the consensus of the multidisciplinary team, don't worry, that is just because we need to be aligned for what is now published global-wise on that. I think it's a statement. Basically, this that is just to show you what is the difference between the 2002 and 2013 that I showed you on the first slide, and then what would be the new type of description in 2024. Based on how the CT scan looks like, that is what we call radiological patterns, and how your lung biopsy looks like, that is what we call histological patterns. Sometimes we need to consider what we have on those tests, plus what are your symptoms, plus all your background history, and all together, and of course your lung function as well, to make a decision about what is the most common disease that actually are you having. And sometimes we don't have just one disease, we can have more than one. And I think that is the reason why the multidisciplinary discussion is really important to establish an accurate diagnosis. And that is one of the tables of this paper. And we have recently published, in less than a month, has been published this state-of-the-art review about genetics here of interstitial lung diseases. One more time, that is just to show up the interaction between the host, that means you as a patient, and how important is the age. And when we talk about age, one thing is about the chronological age, that means how old are you, exactly your age, and different is how old are your telomeres. That means what is your biological age. Is your chronological age, that means how old are you, and you tell me I am 70, okay, you are 70. But if I will measure the length of your telomere, or if I will check if you have any variant, ACA mutation on any of the genes related to your telomere, and I am detecting that maybe you inherited any variant there, is likely that your biological age maybe is 80 or 90. That means if your chronological age is 70 and your biological age is 10 plus or 20 plus, you will experience diseases that are not part of your demographics. And that, I think, is phenomenon that you are having a premature aging because you inherited something from your parents, grandparents, and also that was accumulation of risk factors from the environment, is what we call a genetic anticipation. So all of these concepts that I'm trying to explain in very slow motion, but it's a complex concept that is not even easier to understand for health professionals. And if you can take some method from here, it's really important. Remember, age is not only one age, there is chronological age and also biological age. And then we have the biological sex, that means the sex that you were born, and history of any autoimmune condition, any prior infections, because after every infection we can have a new start. Maybe we were quite okay, well controlled with our disease, receiving the appropriate treatment. Then we have a chest infection, and I'm pretty sure that many of you have this feeling that you had an infection, you are better, but you are never as good as you were before the infection. So that means sometimes this infection, even if it's a bacterial infection or a viral infection or a fungal infection or all together, sometimes they can be the trigger to try to change the behavior of the disease or change the natural history of the disease, and that could be dangerous. And now it's about for other risk factors like a reflux, socioeconomic status, that we know the deprivation and the access of health system as well, unfortunately play a role. The telomere function, we're talking about environmental factors, very important, and also I think genetic factors. Then, when we are talking a lot about the telomere and of course the genomic and stability, but just to let you know that they are not the only factors that play a role. I will not go deeply because these are a bit more, I think it's concept that will require an entire talk, but let me discuss something about the cellular senescence. So all of us, and of course we have our genes, chromosomes, our organs, the cells, when they are robust, younger, as when we were younger, we were full of beings with a lot of vitality. And I think it's our cells are trying to split their cells, and to have, I think, their own children. That is what we call the mitosis, isn't it? They want to, I think, have, their children that are exactly the same like them. And at the beginning, when they are younger cells, they have a lot of power and they are doing that very quickly. But then, when that is a bit more older cell, the division of these cells is not as quicker and is not as good as used to be. And at some point, these cells could be at the lung, at the liver, the blood, and so on. These cells are tired, as we get tired as well when we are getting older, isn't it? And so, at some point, cells, they are very clever, and they say, okay, I am not as good as I used to be, and I will decide that I will not have more little cells or more children anymore. So I think I will not have more divisions. I will stop the mitosis. That means I will enter into a process that is called senescence. So that means it's like a little candle, isn't it? You have a candle and suddenly the candle is getting shorter and shorter, and suddenly the candle is not anymore because it has switched off. So that is what we call senescence. And also, the cells are very clever that at some point, if they will keep going, the divisions, although they should not be having more children because maybe they are a bit having a bit of malignancy or maybe cancer, the cells are able to schedule their own death. And the cell death is what we call apoptosis. And that is really good. That is why the cell cancer, they don't have, because if we have any malignancy, all these cells, they lost the capability and ability to be on apoptosis, and they constantly are on, I think it's in this division of cells that should not be anymore because they are malignant cells. So all of these concepts are important because our organism is very clever. Our body and our chromosomes, our genes are vital, and they are very, very clever. But at some point, despite their effort, if something internally that we cannot see sometimes is happening in an accelerated way, we will suffering some symptoms, or our disease will have more galloping progression despite the appropriate treatment. And that is why if we know what are the features that we need to look at, that could be easier to identify properly. And coming back at this busy table, sorry for that, this table is part of the new classification of ILD, and this is the table 5. And for the first time in this new classification, they include the concept about the telomere-related genes and the telomere length. Never in the previous classification they mentioned about genetic biomarker. They mention now, and they added that possibly or potential use for diagnosis, potential use for prognosis, and clear therapeutic use in case of the telomere-related genes, but emerging value in the case of the telomere length. What that means, this is the present. Precision medicine in ILD is the present, is not the future anymore. What is the problem? That not all the clinicians, I'm talking not only about the fantastic GPs or local respiratory consultants, not even all the ILD clinicians are familiarized with genetics. That could be for multiple causes, but I think it's you as patients, expert patients, if you are aware that this exists, maybe that could be a good conversation that you can have with your clinician, and you can raise awareness to try things to have a type of prevention of these conditions, and at least to minimize the risk factors. So, in terms of, I think, the telomere one more time, just to let you know, and that is, I know that is not too encouraging, but that is what it is. Most of the time, when we have the genetic testing, 50%, if it's not more, of the 50% of the time, we are not able to identify any variant or what is the gene that is the cause of the disease. And of course, this is not good, but that doesn't mean that the patient doesn't have the genetic predisposition. That only means that we were not able to identify this gene that is causing the disease. But when we are able to identify that, the most common telomere-related gene could be the TET, or could be this potpourri. As I said, all of them, they are a combination of letters and numbers, or sometimes could be just a short telomere. I think it's a known cause, and the ultra rare are more surfactant. And it is only a few of the list, is not restricted, of a few diseases that can be, as you can see on the table too, is a combination of idiopathic condition and as well conditions that have a very well-known cause. And that's the thing is very quickly, I mentioned about the telomere length. As soon as we're getting older, become shorter and shorter, and what is trying to do, I think it's this part, I think is trying, I think is to have, I think until the threshold is reached, I think it's during the DNA replication, every time that the cell is dividing, then I think it's the signals of self-death or senescence are activated, and we have an enzyme. As I said, our body is very clever. We have an enzyme that is called telomerase complex that is against this process. And this enzyme, and look that these are the enzyme, this is the components of the enzyme, that is why the genes have these names. This enzyme try to avoid this process, to tell the cell, no, don't auto-destroy yourself. I think is I will repair this part that is missing, and you will keep going because you're still very valuable. And this enzyme is really good, but what happened with this enzyme is not working anymore. So we have a decrease of the activity of this enzyme, and we have the reduce of the telomere length. And that causes our genome system is not stable anymore. We have defect on the DNA repair, and this senescence, that is when the cells become very aged, and I think all is increased. And all of these, okay, it sounds more or less the common sense, but what exactly means for our patients or clinically? That means that can cause premature aging, lung fibrosis, liver cirrhosis, and bone marrow failure. From now on, for patients that we are thinking about a telomere shortening or telomere biology disorder, these three or these four are very well related. So it's not only about the lung, always we need to check about the liver, always to check about the bone marrow or the blood, and also premature aging. That is the reason why we ask about the premature gray hair, particularly if we are in our 30s or younger. That doesn't mean that everybody that have early gray hair when they are teenagers, they have a disease. No, sometimes it would be just because I think all the relatives are very have. But if we have, I think, premature gray hair, plus I think it's a lung condition, ILD, and liver condition, a bone marrow, we have two options there. Or consider that this person or this family have very bad luck, that unfortunately could be the situation, or to try to have a more holistic approach and to say, think a bit, I think it's outside the box, and maybe we are facing a condition that have a genetic predisposition. And the reason for that, I think, is about the bone marrow. We have all of these aspects, and with the liver as well, that explain what is going on. And also, interestingly, these patients will be more vulnerable for infections. And when I said infections, it's not only about chest infections, any type of infections. Why? Because the immune system is not working at 100%, and particularly the T cells, they are weaker. So therefore, their capacity to fight against infections is not the same. And that is important, particularly for patients that are under consideration for transplant. So these aspects are important, and that is how we can embed all the information that we have about genetics to the standard of care. Now, we talk about CT scans, and of course, I'm not pretending that you will be experts about how to read CT scans, and we are not in front of radiologists. Just to say, unfortunately, we don't have a CT scan that will be the same one for all the patients with genetic predisposition. Unfortunately, we don't have. And even CT scans at the beginning maybe looks like not too bad, like this one, for example, is a patient with IPF, with a CT scan that looks a bit of, that is some airways that has been pulled out, that is what we call in medical terminology traction bronchiectasis, that is airways that has been pulled out from the peripherally, or sometimes we have honeycombing. And this CT scan looks slightly worse compared to this one. But this patient, that they both have the same lung function and the same age, similar diseases, other diseases are part of ILD, but this patient only have a common variant, that is the MUC5B, and this patient have one of the telomere-related genes. Although this CT scan looks slightly better, I would be more worried about how the disease will behave for this patient rather than for this patient. Why? Because I know that the telomere-related genes behave in a more gallopant way. Plus, this patient likely we will need to keep an eye more closely about some liver function abnormalities and how will be some full blood count abnormalities and so on, and looking at as well the probability to acquire more infections. And that is just, I think, CT scan for a patient with rheumatoid arthritis associated ILD. Another aspect, even if you don't have time to read what is here, the legend of Figure 2, but if you see this survival graph, whoever are the patients that are on the purple line, they are not doing well. Try to guess who they were. They were patients with pulmonary fibrosis, younger than 60, and also with short telomere. That even if you adjust that by treatment that they are receiving, type of diagnosis, definitely genetic background matters. And so it's really important to try to categorize and to see what is exactly going on with the biological aspect. And we have this information now. This publication is from 2019. It's quite complicated, this graph, and maybe let me explain it for you in this way. Years ago, and that is before 2019, I'm talking about 2011, before the antifibrotics that you would know very well for idiopathic pulmonary fibrosis, that they were published in 2014, that they were nintedanib and pirfenidone. Before them, 2011, we had a publication for a study that was called PANTHER. And the PANTHER study was the study that is for IPF patients, that the recruitment was for patients that were on placebo, that means without any medication, versus patients that were on oral steroids, prednisolone, plus immunosuppressive therapy, azathioprine, plus N-acetylcysteine, versus the ones that were only N-acetylcysteine. At that time, we didn't know even, because the antifibrotic treatment didn't exist. And the way how our colleagues used to treat patients with IPF was with immunosuppressive therapies and steroids, things that we don't do that anymore. Because thanks to this study and thanks to the patients that participate in this study, we know that if we use steroids or immunosuppressive therapy to treat patients with idiopathic pulmonary fibrosis, it's not only not beneficial, it's dangerous and increased mortality. Okay, so we learned that lesson from 2011. What happened? That remaining samples about genetics for this trial were analyzed and published in 2019, and they discovered that particularly the patients for this trial with short telomere are the ones that have a worse survival when they were receiving immunosuppressive therapy. That was the same in a different trial. That was a trial years ago that they tried to see if an anticoagulant medication could be good as an antifibrotic. The answer is no. We don't use anticoagulants for antifibrotic properties. They had the samples, one more time, the same. Patients with short telomere and also using prednisolone or azathioprine were the ones with a worse prognosis. And that was replicated one more time with a cohort from USA, from San Francisco. The moral of this story, take-home message, in patients with a genetic predisposition, particularly a telomere disorder, we know that the use of high dose of steroids or immunosuppressive therapy is dangerous and can increase mortality. So that is a reason why it would be important to know what exactly is the risk that we have in our genes. And this is a bit complicated.